Hello friends. So I'll just give a very brief overview on the role of Milrinone in subarachnoid hemorrhage vasospasm. So there are a lot of drugs that are used for vasospasm. So of late, I'm sure many of the listeners would know that Milrinone is commonly used. So we just thought look into what's the current prevailing evidence. So I'll do another video on all the other drugs that have been tried, like magnesium sulfate has been tried, and the recent trials have not shown good benefit. And statins, high dose statins were at one point of time utilized, but now also that has not shown to have any great outcome benefit. And of course, nimodipine, there are a lot of earlier trials which have shown benefit. So now the two drugs that are commonly used are milrinone and nimodipine, which remains the mainstay. So I won't be covering about evidence for intraarterial milrinone because there are at least around 20 studies which are shown like intraarterial papaverine or intraarterial milrinone, but I'll be talking on systemic milrinone, which is more pertinent to our ICU because we can use it in a systemic way, and that is and what is the current prevailing evidence. Just to recap, so milrinone is a bipyridine methyl carbonitrile. So that is the chemical structure of milrinone. So for all of us, we need to understand how this acts. So it is a phosphodiesterase 3 inhibitor. So the mechanism of action is fairly straightforward. So it is a phosphodiesterase 3 inhibitor, which reduces CAMP degradation. So cyclic monophosphate degradation is what it reduces. So, and this leads to increase in the calcium stores. So there is increase in the calcium availability because of the reduced degradation of CAMP. And because there is increased calcium available, there is influx of this calcium into the muscle cells, and there is increased contractility of the muscle cells. So basically, it enhances the cardiac contractility or the muscle contractility by making the local calcium stairs available by reducing the CAMP degradation. Along with this, it is a potent vasodilator because of the similar mechanism of actions. It is a vasodilator. So it is the arterial vasodilator. So this is the basic mechanism of action. And since milrinone is positioned as a treatment modality for vasospasm, it's predominantly in its role to cause this vasodilatation. The half-life of milrinone is around 50 minutes. So any subarachnoid hemorrhage that we see, for all the trainees, we need to understand. So there are around 4 common complications that tend to occur, which is very beautifully depicted in this diagram. So the one common complication after subarachnoid is the seizure. So obviously, you need to put in efforts to make sure that they do not have seizure. The second complication is the rebleed. So that is obviously, it depends on whether patient has undergone coiling or clipping, and this is to prevent rebleed. And the third commonest complications is vasospasm-induced delayed cerebral injury or delayed cerebral ischemia, DCI, which we call. So delayed cerebral ischemia secondary to vasospasm is an important complication. And fourth important complication is hydrocephalus. So these are the 4 common complications which adds on to the morbidity of subarachnoid hemorrhage. So today in this, we will only discuss about how milrinone is helpful in mitigating the delayed cerebral ischemia. And so 30% of subarachnoid hemorrhages are known to have a DCI due to vasospasm, delayed cerebral ischemia. And the duration, the timeline at which this vasospasm occurs to cause delayed cerebral ischemia is 4 to 14 days. So immediately after subarachnoid coiling clipping, it does not occur. It occurs 4 to 14 days. It tends to peak in the second week is what is traditionally we are all aware of. And how do we suspect there is delayed cerebral ischemia or there is vasospasm? For all the trainings, we need to look at focal neurological deficits. So please, so there is a definition of focal neurological deficits. If there is reduction in GCS by 2 points, and this lasts for around 1 hour, that's when we call the patient has developed focal neurological deficits and possibly vasospasm is setting in. And sometimes these focal neurological deficits can be very subtle. Like they can even have hemianopia, or they can have aphasia, or they can have slurring of speech or hemiparesis. So these are some of the commoner FNDs that may manifest, and you need to have high index of suspicion if hemianopia is prevailing as FND. So or reduction in GCS for 2 points lasting for 1 hour qualifies as FND. So these are the just a pictorial representation of some of the key complications that you need to be aware of the subarachnoid hemorrhage. So we'll jump into what are the studies that have been done for the role of Milrinone in vasospasm. So most of the studies have come from France. So this study has come in 2021 in Neurocritical Care by French group. It's called Milrispasm trial. As you see the title, intravenous Milrinone for cerebral vasospasm in subarachnoid. So I'm only talking about systemic IV Milrinone because intraarterial Milrinone, there are at least 20 studies, small case series studies, all have shown to have some benefit. So this is on IV Milrinone. So here the dosage they've used is IV Milrinone 0.5 micrograms per kg per minute. So they had 94 patients, 41 patients were in Milrinone group along with induced hypertension to prevent vasospasm. 53 patients were in only hypertension group. So they looked at 6 months functional disability, and 6 months functional disability was lower where Milrinone was used, or in the Milrinone group. If you look at adjusted odds ratios 0.28, and if you look at this confidence interval, it is statistically significant. So they found functional disability was much better, or they had less functional disability in Milrinone group. And they looked at delayed cerebral ischemia, that also was lower in the Milrinone group, adjusted odds ratio is 0.19. And as you see, confidence interval is statistically significant. And the need for rescue angiogram to give intraarterial nimodipine or intraarterial Milrinone or intraarterial papaverine, so on and so forth, was also significantly less in the group which got IV Milrinone, 15% as opposed to induced hypertension. 53% needed rescue procedures to address vasospasm. But the Milrinone group had a little higher side effects with regards to hypokalemia, hyponatremia, and polyuria. All this can be definitely easily managed in ICU. So the Milrispasm study is what every trainee should at least be aware of, which is the evidence available for usage of IV Milrinone for preventing or for treating vasospasm. So before this, there was another trial, another study, which again came from the French group. So where they compared which protocol for Milrinone to treat cerebral vasospasm associated with subarachnoid hemorrhage was better. So they compared two protocols in this particular study. This came in Journal of Neurosurgery in 2019. So here they had 101 patients. And as you see, they had 24 patients who were put on intraarterial plus intravenous Milrinone. And they had 77% who were on only IV Milrinone. So they compared two protocols where some group, a small group, 24 patients, underwent intraarterial Milrinone along with IV, and they looked at revision rates of any procedural sort of a salvage measures, and they saw it was comparable. Even IV Milrinone was as good as intraarterial with intravenous Milrinone, and the need for rescue procedures also were similar between IV and intraarterial plus IV Milrinone. And good neurological outcome also was similar. So this particular study possibly paved the pathway for Milrispasm study, where they compared IV with Milrinone with an induced hypertension. So basically, this study highlights that if you have IV Milrinone, that is as good as giving intraarterial plus intravenous. And the median, the modified Rankin score, which qualified as good neurological recovery, 0 to 2, was similar in IV and intraarterial Milrinone. So these are two reasonably good studies that we have to substantiate that IV Milrinone is as potent as intraarterial Milrinone. And the new trial that is currently happening, again from the French group, is a Milrinone infusion for vasospasm treatment in subarachnoid hemorrhage called MIVAR trial. The enrollment is still happening, so it would be exciting to see what this trial is going to show. This is a French multicentric trial, similar to possibly Milrispasm, where IV Milrinone is being used and recruitments are happening. So this is all we have evidence with regards to IV Milrinone, and in which is now we could fairly sort of bear in mind that this is as good as intraarterial Milrinone. So based on this, they have come out with an algorithm based approach for how we should use IV Milrinone. This is useful for all our trainees, and maybe you can create a protocol in your ICU and keep it. And maybe in our ICU, we will try to create a protocol out of this. This is just give you some sort of a framework as to how we should be using it. So if there is delayed cerebral ischemia, So the first step would be to give fluid resuscitation. So you have to ensure the patient is euvolemic and it is not hypovolemic. And then one can consider Milrinone. The dosage is 100 micrograms per kg bolus, and the maximum you can go up to is 12 milligram, followed by 0.75 micrograms per kg per minute if delayed cerebral ischemia has been proven. And after that, one can titrate with incremental. So basically, for all our trainees, bear in mind, you can start with 0.5 to 0.75 micrograms and go up to 2 micrograms per kg per minute, maximum of 1 milligram. So that is the sort of a dosage you should have in mind. So after that, you can titrate with increments of 0.25 micrograms per kg per minute every 30 to 60 minutes to break the vasospasm or to attain good vasodilatation. And after this, they have divided into mild vasospasm. I'm sure all intensivists have taken a video on transcranial Doppler to determine the severity of vasospasm. More than 120 centimeter per second, we call it as mild. More than 120 to 160 and more than 160 and more than 200, we call it as moderate and severe. So keep that in mind. If it is mild vasospasm, the Milrinone suggested dosage is 0.75 to 1.25 micrograms per kg per minute. If it is mild vasospasm. If it is moderate vasospasm, where you have more than 160 centimeter per second, use Milrinone at a dose of 1 to 1.5 micrograms per kg per minute. If there is severe vasospasm, where it is more than 200 centimeters per second, then use at a dose of 1 to 2 micrograms. So basically, 0.75, the maximum is up to 2 micrograms per kg per minute. So you can create a protocol and keep this in ICU. If there is no improvement in 3 to 4 hours, even with all this, then you have to think of intra-arterial. Then you have to take the patient for angio, and intra-arterial Milrinone is given at a dose of 4 to 10 milligram bolus as an intra-arterial. If there is improvement, continue IV Milrinone, and it is suggested IV Milrinone to be continued up to 72 hours after the vasospasm is been identified and once the correction of vasospasm has been done. So this is a simplistic sort of a protocol that possibly you can follow and have some clarity on the utilization of Milrinone. And we looked at how the Milrinone acts and we looked at what is the current evidence. So it would be exciting to await the trial of MIVAR trial. So right now we have two reasonably good studies, Milrinone spasm study and another French protocol which compared IA with IV along with compared to IV Milrinone, and they were found to be similar. So that's about it, friends. So request all of you to submit your valuable work to Journal of Acute Care and visit my website to rehear to this lecture. Thank you. Thank you, Vinod.